So this is angina of your legs, and it is called intermittent claudication. So angina is only to be used for the heart. So if you use angina, you're having heart pain. If you're having leg pain from peripheral vascular disease, it is intermittent claudication. So it is ischemic muscle pain that's caused by a constant level of exercise. Hey, just like angina, it should resolve with rest. So you're taking a walk, and you're like, dang, ow, that really hurts. And you stop, and it goes away. And you're like, okay. And you keep going. Is that a Charlie horse?
Yeah, maybe.
Does Charlie horses go away with rest?
Oh,
No, those puppies are a muscle spasm. That hurts. So it's not just a Charlie horse. Could be not be. But this is someone, okay, you got a 70-year-old guy with a history of hypertension and a high cholesterol. He's on a statin. He's on some blood pressure meds. And he's taking a walk, and he's like, dang, every time I take a walk, my legs hurt. And it happens every time. Not just, once a day or whatever. It happens every time they walk. Because every time they walk, what is happening? What are the muscles doing? They're working. And are they getting enough oxygen to do that? No, they got a blockage in the legs. So it is reproducible. Every time they do something, it hurts. It is not as big of an emergency as cart pain because, it's not pumping anything around our body. We're just walking, so people just stop walking. They're like, okay, good. If I put my feet up on a recliner and never move again, I never have that pain. Done. No. They also can have paresthesias, numbness or tingling in the toes, feet, loss of pressure, and deep pain sensation. Why? Why do you have numbness and tingling in your toes? No blood flow. Guess what? Those nerves died. They didn't have blood flow. Nerves died. Muscles can create energy another way. They can get lactic acid. They can get some energy the other way, and they can do their job. Nerves, they just die. So those nerves died off because of lack of blood flow. So basically, over time and lack of blood flow, they start getting numb, tingling toes, and maybe they don't have the intermittent claudication yet, but they start with numb, tingling toes. They can have pain at rest. Do you think this is stable or unstable? Unstable leg pain, unstable intermittent claudication. If it's unstable, they're having pain at rest, then what are we having? A massive blockage to your legs, to your feet, and they probably need some kind of intervention. It's not an emergency, you're not going to die, but you are basically exhibiting no blood flow to your legs. If you're having that much pain at night that you can't even rest without your legs hurting, you have some serious blood flow issues to your feet. Do you think they're going to have great pulses and cap refill? No. So, this is what it looks like. This grows for a while before we see it because, of course, this is happening over time. And it's not as serious as when the heart has angina. So they walk for a while and they rest and they're doing okay. Maybe some days it's good, some days it's not good. But, they're mostly now sitting a lot. And now they notice that the legs start to swell a lot. And they don't have much hair growing on their legs. Their pulses are weak. What is happening to this leg? It is dying. Slowly, not consistently, but intermittently. Blood is not getting to places where it needs to go. So this thin, shiny, taut skin is due to a lot of edema. Okay? It is swelling. Why is it swelling? The circulation's bad down there. Things can't get back up. We're walking with gravity. It's hard for fluid to get back up out of the legs, especially legs that are all blocked up. If your arteries are blocked up, your veins are blocked up too. Everything's blocked up. So they start to swell. They lose hair because there's not enough oxygen to nourish hair growth. Diminished pulses because there's not enough blood flow down there. You elevate the foot and it goes white. Well, they don't have enough blood flow. They can't get blood flow. You can have atrophy of muscles because they're not getting enough blood flow. Delayed healing, wound infections, non-healing ulcers because there's no blood flow. Okay, this is a leg in crisis, but it's not a priority organ, so we let it go for a while. So we start to see symptoms. A heart, we wouldn't see this. We can't see the heart, but maybe a big swollen heart looks like heart failure. So we see big swollen legs, and they look pretty gross and horrible. But these are also just some, basically coldness, bad peripheral pulses, pallor, hair loss, bad growth, edema. There's all symptoms of peripheral arterial disease. We're worried about their tissue perfusion, right? They have blockages in the arteries to their legs. They are getting poor perfusion to their legs. We're worried about their tissue perfusion is getting connected. This is not going to affect your brain or your heart unless you have atherosclerosis in those areas as well. But what we're worried about for this is we don't want this leg to die. If this leg dies, it's going to have to get cut off. There's no help for it. So we want to make sure that their tissue is perfusing. So we need to assess the patient. So the patient comes to you and says, every time I walk, it hurts. What are you going to look at? You're not going to sit them down and give them oxygen, because this isn't like an emergency for your heart. You're not going to give them nitrates or anything, but you are going to assess them. You're going to sit them down and say, does it go away with rest? Well, yeah, it's fine now. I'm just not going to walk anymore. Well, see how bad down the spectrum we are. See what these legs look like, okay? Let's do color, temperature, cap refill, pulses, sensation, movement. Because if we're pretty far down this spectrum, this patient's tenuous. They're not going to have a leg attack, but they could lose peripheral circulation to the point where they lose their leg. So we want to see how bad this leg is. So you take a look at this guy, you get him up there, and you can't feel his pulses. Where are they? His foot's cold, you can't feel his pulses. What do? You can probably call somebody. They don't have pulses. What's going to happen? It's going to die. This is very similar to cutting off your finger. You're cutting off your leg circulation. So we're going to check the pulses sensation. So if they are numb, cold, very weak or no pulses with very long cap refill, that's much more of an emergent thing than, oh, they're having pain. And yeah, they've got they've got pulses. They're not great, but they have pulses. They don't have any diminished sensation. Their foot's warm. They're not as far down the spectrum as someone who is. You've got to assess them. Just because they have peripheral arterial disease might not mean you're going to see a certain sign or symptom. It depends on how far along this has been going, where you're seeing this patient. Assess your patient. Assess them for their pain. So look at their legs. Ask them about their pain. Does it get better with rest? Does it get worse with activity? Look at their skin. And, of course, they're going to get all the patient education for lifestyle modifications that all the other patients do. Hey, you've got peripheral arterial disease. Are you taking your statins? Are you doing your things for your cholesterol? Are you eating a better diet? Do you think these patients should be restricting their sodium intake? They've already got problems with their circulation and swelling, yes. Anything that's for the modifiable risk factors will work for these patients as well. Patient education. They also need to take care of their legs, especially if they can't feel them. So risk factor modification goes for all these people. They are having problems with blood flow. What are we going to do to help their blood flow? We can't give them nitrates for their legs, can we? Do we give them nitroglycerin for their legs? No, not really. So we're going to make sure that all the risk factors are getting better. We actually want them to walk, because if they tone their muscles, they won't use as much oxygen. They'll get better at utilizing oxygen. The more you use a muscle, the more effective it gets at utilizing oxygen. So we actually want them walking, and they don't want to walk because it hurts to walk. Is it okay to be like, nah, you're good, just sit? No, you're going to have to kind of walk through it. What you can do is tell them, yeah, you need to walk for 30, 60 minutes. You don't have to walk nonstop, but walk, stop, go to the mall, place with a lot of benches, And when it starts to hurt, you stop. But you've got to tone that muscle so it does better, okay? Now, that's for stable, because we're basically talking about stable intermittent claudication, where when they rest, it stops, okay? So that we're going to tell them to modify their risk factors and continue to walk, try and tone the muscles, try to keep some of this going. They're going to take their statins, very similar to stable cardiac, right? They're going to modify their risk factors, they're going to take their statins, they're going to try and, modify their exercise, stop if it starts to hurt, but they just don't have the nitrates that cardiac does. So they're going to walk, they're going to do things, they're going to take care of their feet, especially if they have numbness on their feet. That's just there. You should probably have seen that already somewhere, right? Mm-hmm. That's just a little extra thing. The treatment for it, they don't have nitrates, but they get ACE inhibitors. And I don't know why ACE inhibitors. Everybody asks me, why ACE inhibitors? It works. What are they going to do? It's going to stop vasoconstriction, right? Because we're stopping the renin-angiotensin system. It's going to stop vasoconstriction. It's going to decrease your fluid retention, right? Which is also a problem for them. They got too much fluid. They can't circulate very well. So it will decrease that fluid retention and sodium retention. ACE inhibitors work. It helps the blood flow by vasodilating. It helps patients walk longer without pain. ACE inhibitors is what they like to start people on who are having intermittent claudication, who are stable when it resolves with rest. They can also use these other two, which I have not seen that much, but maybe you've seen them in clinical or not. They're the two most common, according to somewhere I read, but meds for intermittent claudication. We don't have nitrates, but we do have these three.
Do you want us to know those two other ones?
I don't think I put them anywhere in the test. You can look them up. But there are intermittent claudication meds. Basically, if your patient is having stable intermittent claudication, it goes away with rest, what are we going to do for them?
ACE inhibitors.
Well, first you're going to have them rest. And unlike heart, where you want them to walk. Okay, you're going to teach these patients, basically, if they're having intermittent claudication, they need to see their doctor. They need to follow up with their physician. They need to control their hypertension. They need to modify all the risk factors that they can, and they need to walk. All right, you're going to educate them is all we can really do for them, and keep monitoring them. They need to see their doctor. They need to be continuously assessed, because if something's going wrong or that blockage is getting worse and becoming unstable, where they can't walk without pain, the pain doesn't go away without rest, they're starting to lose sensation and pulses, then what do we do? Well, probably meds, and then if the meds don't work, they get opened, just like hearts. They go get opened. They don't get opened in the cath lab. They get opened, well, they can. They can go to the interventional suite, the cath lab, and get this balloon, but instead of the balloon going up to the heart, it goes down to the femoral arteries and does all the same things. You can get a stent. You can get a balloon. They can roto-rooter that little puppy. They can go in there and do some things. So they've got to open the blockage. And when do they open the blockage? When you're starting to have unstable pain in your legs. When you're having pain at night and losing sensation and pulses to your legs, it's time to go and get an intervention.
If you want to do this when they're stable, is it
They will do
elective?
it.
So you have to
Yeah,
say,
they
I want
can
you to
do it elective. They can do it elective. That is going to be a decision between the doc and the patient. They're not going to do it until they're starting to, they probably will try meds first. They're going to say lifestyle modifications, keep your blood pressure under control, take the ACE inhibitors, take your meds, and if those are not working and you're still having diminished circulation, diminished sensation, pain at rest, now we're going to do procedures. Okay, it's not an emergency like the heart attack. You've got some time to plan. This is working with the doctor. But they can go in. These are elective this way. They can go in. Stent things, open them, so they might say they have a femoral stent. They may have gotten a couple of stents. Well, that's what they're doing. They're going in there and they're ballooning that thing open just like they do to coronary arteries and putting wire cages in there to try and let blood flow go through. They can do the roto-rooter. They can also do bypass surgery. We didn't talk about heart bypass surgery. We said that was the last step. If they can't revascularize via, the cath lab, they'll go to heart bypass surgery. Well, this is leg bypass surgery. It's not different, it's just in a different location. But they will actually take other veins and use bypass. We are making a bypass for that blockage. And they can do that surgically. So you have patients that have had a couple of failed stents in their femorals. And they still are having pain and bad pulses and bad cap refill and pallor. Okay, well now they need to move on to surgical intervention. And then if that doesn't work, which we've had many people have stents and have bypasses. They have a fem-pop bypass. Have you seen that on anybody's history? A fem-pop bypass. What are they doing? There's a huge occlusion here. So they are going from the femoral to the popliteal artery and making a big long bypass. Fem-pop bypass. Or a fem-fem bypass, where they actually take vessels from either side and bypass. They do 2 femoral bypasses. This is some bad circulation going on. These people look hideous legs. Hideous legs. And what do you think we are watching on them? What are we watching on patients that have had fem-pop bypasses, fem-fem bypasses, femoral stents, popliteal stents? We're watching their pulses. You are watching their pulses, cap refill, and sensation. That's how we know whether it worked or not. Pulses, cap refill, circulation. Peripheral vascular disease, watch their circulation. Watch their circulation. If it is not getting better after all of those things, they're just like, hunk. There you go. It's gone. They will amputate. So that's the arterial side. It is angina-like pain. What's it called if it's in the legs? Intermittent claudication. Stable intermittent claudication means it goes away with rest. What do we tell patients with stable intermittent claudication to do? Walk. Keep exercising even if they don't like it, but just rest in between. Maybe they're on an ACE inhibitor. They're on a statin risk factor modifications. If it gets worse, then they'll need to speak with their doctor about possible procedures to help get rid of some of that atherosclerosis in their legs. And they will have procedures or surgical procedures. And the whole time, what are you assessing on these people at all times? Circulation, please. Thank you. Pulses, cap refill, sensation, circulation. So now we're going to talk about DVT. This is athrombosis. This is an actual clot. This is not a plaque. The plaques are building up in the arteries. That's all disease. This is an actual clot. Have you talked about these before? This is a blood clot. Blood clot in your leg. This is not atherosclerosis. This is a blood clot in your leg. So you can have a whole lot of reasons you could have a blood clot. You could have cardiovascular disease that's, maybe it's not a blood clot, but maybe it's like a little plaque clot, like you said, when they break off. They can break off. If they do, and pieces of it break off, you can have a clot. But the blood clots are usually from surgery, prolonged mobility. Anytime blood does not flow, it clots. That's what it's designed to do. So if blood does not flow, it clots. So anytime you are hanging around, sitting, studying, sitting on a plane, sitting on, a chair, doing whatever, your blood is not moving, right? It's late. You got your legs down on the ground. What moves our blood in our venous system back to our heart? Your muscles. Your muscles are your squeezers. What are they in the hospital when they're not walking so much? What are your squeezers? Your squeezy boots that you put on their legs. We're doing that because they're not walking as much. When you get up and walk to the bathroom or you do anything, during that time, you squeeze. So if you've been pregnant and you have feet swelling, what do you have to do to get rid of it? Elevate it or get up and walk around. But the dependent edema, that's stasis. Anytime you have stasis, you've got to get rid of it because blood that sits clots. So if you're sitting around for a long time dependent, you've got to get up and move them around. Get rid of that edema. Why do smoking, obesity, why do these two cause risk factors for DVTs?
Lack of circulation. Stagnation.
Yeah, this is stagnation, this is damaged vessels, a lot more blood, little bleedings, little micro bleeds all over the place, and those little micro bleeds all clot off at some point. And the more little micro bleeds and more vessels you have, the more chances for clots to form. Estrogen actually helps your blood clot. So supplemental estrogen is found to increase clots in your legs. Pregnancy, because of course you're just stasis of blood all over the place, and family history. So if you have blood clots, the one thing we don't want is that clot getting to your lungs, because you end up with a pulmonary embolism. Okay, have you heard of a pulmonary embolism?
Yeah.
Okay, it's what we want to avoid. We should never ever have one. We want to avoid them. That's why you hear DVT prophylaxis, deep vein thrombosis prophylaxis. It's really pulmonary embolum prophylaxis is what it is. We don't want the DVT to form in the leg because what happens in a deep vein thrombosis, sometimes these things are huge. I've seen deep vein thromboses that are thrombosi that are this long. They're huge. They're like big strings of clot. If those things fracture or get up into the lung, then the lung is the teeniest, tiniest microvessel that you have. And things will definitely get wedged in there. If a clot gets up into your lung, it cuts off circulation through that lung. I'm going to draw a quick little picture that I will use again and again and again. This is one side, this is your right heart. These are your very well-drawn lungs. And this is your left heart. Your heart is actually separated by your lungs. The right heart and the left heart are different. They're in one organ, but the lungs flow between them. Okay? Now, the vessels on the outside here, they are on the outside of your lung space. All these vessels are on the outside of your lung space. What's on the inside of your lung space? What's on the inside of your lung space? Air. Okay? Air's on the inside, blood circulating around on the outside. What is the blood circulating on the outside doing? Picking up and depositing stuff from the inside. The inside is full of air. The outside has blood flow around it. Okay? So what's happening is the right heart dumps into this circulation. It's not into the lungs. It's into the blood flow around the lungs. And then it will go back into the left heart, all oxygenated, beautiful, and heading out to your body. So if a clot came from your leg, let's draw Mr. Clot, heading through the right heart. It's traveled through here. It's traveled through, and it gets stuck in this tiny vessel. So what has happened here if it's stuck in there? Well, you have a pulmonary embolism. And what is happening to all the blood that's traveling behind it? It's getting stuck. There's a big wall there of blood. So what is happening on this side? No blood. Nothing. What is happening on this side?
All the blood.
All the blood. What is happening to your air? It's just going in and out, but none of it is getting to your body. Okay? So if it happens high up in the lung vasculature, you're dead. All right? If a pulmonary embolus happens at the front part of your lung vasculature, that's the end. Those are the pulmonary emboluses that kill people on airplanes because they get up to do something and they drop because blood flow stopped. There's no blood going out to your body. No oxygen, no blood. You are dead. It's gone. That clot has killed you. Not all pulmonary emboli do that. Some are smaller, and they make it through further, because remember, this is like billions of little vessels, billions of them. So some of these clots make it down here, but there's still blood flowing all around. There's just a tiny clot in the lung. A tiny clot in the lung will shut down this part of the lung. This part of the lung is no longer getting blood flow. So that part of the lung is no longer exchanging blood. But there's still oxygen exchanging here. So you're not dead, but you're not getting full amounts of oxygen exchange because this little piece is now no longer perfusing. What do you think your symptoms would be? Shortness of breath, chest pain, cough, hypoxia. Not because there's anything wrong with your respiratory system. Your respiratory system works great. Air is coming in and out, but not enough blood flow is getting exchanged. So you end up short of breath and you have a cough because they're like, what's going on? I got something in there. It's not in your airway, it's in your vasculature. So you can have minor pulmonary emboli, you can have massive pulmonary emboli. A massive one, you don't have any symptoms other than death. A massive pulmonary embolus will kill you immediately. A minor pulmonary embolus will cause shortness of breath, cough, hypoxia, and can cause right-sided heart failure because there's still blood backing up. There is a big clot there in the way. Some other blood's going through the other tunnels, but that tunnel's cut off. So you can see, if you see shortness of breath, chest pain, cough, hypoxia, and the patient's got great air exchange, but you put on the sat and it's 58, what's going on? We got to go figure it out. How do we find out?
Chest X-ray?
You get a chest, not a chest x-ray so much. Chest x-rays won't really show you what's going on in the vasculature. It shows you the airway. When you get a chest x-ray, lungs look great. Lungs look beautiful, but you got no oxygenation. So you're like, what's going on? So they send you to a CT scan where they can see the vessels and they see the pulmonary embolus in the vessel. So you have to do a little bit more exercise, a little bit more studies to figure out what's going on. But your lungs, air-wise, great. Blood vessel-wise, not so great because there's a big clot in them. And this is a picture of all the different places there you can be. Here's a little clot. This clot, these two, would cause a lot more symptoms than this one down there. So it just depends on how deep into the circulation that clot has gotten. So a patient with any of the risk factors that has shortness of breath and bad oxygenation, you should consider pulmonary embolus as a choice. But the most important thing is to prevent it. So we're going to keep people moving. This is why we get people up out of bed when they don't want to get up out of bed. When it's a pain in your butt to get them up out of bed, it's a pain in their butt. Nobody wants to do this, but they have to do it. Because the more they move around, even the motion of moving the leg over to the side of the bed and dangling it and trying to stand, that's all muscle movement that will help blood move. Yes?
Besides surgery, surgery is performed like, I would say trauma, but being like a traumatic accident, like
Yeah.
MBA and that kind of thing, that also increases the risk.
Anything that has stasis, because if you have a broken bone in your leg, there is blood stasis around that, and so you get a clot around it. Anytime blood has slowed around something, you have a risk of clot.
So when you're in like the ICU, you're doing a passive range of motion for your patient or something, or something like that?
They get the squeezy boots, passive range of motion, mechanical prophylaxis. So you're probably going to do one of each of these things. You're either going to be making your patient get up and move around, or even if they don't move around, they could pump their feet, right? That will do muscle movement. Active or passive range of motion. Get them up if you can. Mechanical prophylaxis. SCDs, squeezy boots, sequential compression stockings, whatever you want to call them. Squeezy boots. I call them squeezy boots. It's what they're doing. They're squeezing. So that's mechanical. TED hose and compression stockings have been found. That's great. They're great supplements to muscle movement. We can wear them as we're all wandering around for our 12-hour shifts or whatnot. They found, though, that hose by themselves without the mechanical squeeze aren't really that good, and they ended up causing a lot more skin damage to patients with edema and stuff. So they would rather you do SCDs without TED hose than TED hose. But if patients are out and about and they have peripheral vascular disease or peripheral artery disease, compression stockings are a great way to help move blood back up. But really, SCDs, if your patient is immobile, is really a gold standard. And then medication prophylaxis. So you don't just pick one. You do as many of them as you can, okay? Because the more you get, the better your prophylaxis. So the bare minimum is this one. If your patient has surgery or risk factors, they should be on some kind of anticoagulant to help prevent that clot in the first place. The best would be these squeezy boots and out of bed to the chair. Some people can't. What's the risk factor with getting medication prophylaxis? Subcutaneous heparin.
Increased bleeding risk.
Increased bleeding risk. We don't want people having bleeding risk too. On top of it, if we can get them up and moving, that would be better. The active ways are better, but sometimes we just overkill. We're going to hit everything. We want them out of bed. We want them wearing their SCDs when they're in bed. We want them getting the prophylaxis, and we want them range of motion.
How do you get someone off of heparin? Because I know people who take warfarin need it for a reason, but if you're on heparin,
You can just stop it.
Can you just stop it?
Yeah. A DVT looks a little different than peripheral vascular disease. It looks like an infection. A DVT looks like an infection. It's pain, it's swelling, it's warm to the touch, it's redness, possibly bluish skin below the affected area. This is not so much perfusion. This is a blockage and an irritation, and your body is trying to get rid of this clot, and it's attacking this clot, and it looks like an infection. Peripheral vascular disease, does it look like an infection? No, it looks like low blood flow is what it looks like. This looks like an infection. And then if you see the word Homan sign, it just means that when you put your foot up, it causes a great amount of calf pain. It's not the only diagnostics tool. You'll see edema, swelling, and warm to the touch and redness. Don't torture your patients by pushing their legs up and making them go in pain. If you have all this, oh my goodness, what are we going to do to find out if we have a DVT? Ultrasound of the leg. Ultrasound of the leg will tell you whether you have a DVT. So I don't think I even wrote, did I write ultrasound of the leg? You should do an ultrasound of the leg to confirm. But red, swelling, pain, warm to the touch, high chance of DVT. Ask for an ultrasound. Check your pulses and everything. Make sure everything's good. But if you have a DVT, what do you want to make sure is in their chart? We want some kind of prophylaxis. We want to make sure they get prophylaxis. Now, you're going to make sure that they get their prophylaxis, their anticoagulant therapy. They should have their heparin, their Lovenox, whatever it is on their chart. Rest and comfort, maybe bed rest. So there's a big argument over bed rest and not bed rest. I will go with whatever your book says. What's the argument for bed rest? They have a clot. We're not preventing it anymore. It already exists. We don't want it showering up to the lungs. So people will say bed rest, and then they're like, well, then why do we put on SCDs? We're just squeezing it up to the lungs. But we're preventing more. Basically, we already have a clot. All it's going to do is get bigger until those anticoagulants start to work on it. So there is a lot of debate now over SCDs and bed rest versus getting them up and keeping them from getting worse.
Is it doctor's preference?
No, it's, the doctor will order bed rest or non-bed rest. Right now, we're almost done. Right now, the bed rest with SCDs is the current best. But whatever your book says, I will have to go through the new edition of the book and see what the book says. But right now, we have patients stay on bed rest so they don't shower any clots, and we do let them wear their SCDs to prevent more clot from forming on it, because they found that squeeze of the SCDs isn't enough to project a clot out, but walking may be. So you can follow more research and find out. This is where we get our evidence-based, everything changes. But keep them pain-free, keep them circulating as best as possible. Their anticoagulant therapy is going to be heparin or Coumadin. And then heparin is short-term, Coumadin is long-term. Once you've had a clot, it takes months to dissolve a clot. Months. So they will be on heparin for a little while to get it under control, and then they will go home on Coumadin. If you have a clot, you will end up home on Coumadin. That is long-term therapy. Heparin will be monitoring labs while they're in the hospital. Coumadin, they need to monitor their PT-INR outpatient. They will need to monitor it almost weekly for a while until they get it right, and then once they get the right dose, they will need to monitor it very frequently, like every few months. So do not let them think that they have to go see the doctor in 6 months. If they're on Coumadin, they're going to be following their labs closely. They can go in and thrombectomy, remove a clot, something like I was talking about, those big long clots that are, inches long. They may have to go in through the cath lab. They'll go in through the venous side and actually pull them out. And that's where you see them laid out on surgical tables, these big long clots. Look up surgical removal of a DVT on YouTube, and you will be horrified by the size that these clots can get to. If you are highly prone to clots, you've had multiple clots, they may put in a filter in your vena cava, which is your large vein returning to the heart. They put in an umbrella-like cage that will catch clots before they hit the lungs.
But won't that just fill them up?
They will. They will, so they have to probably kind of keep an eye on them. Yeah. They probably have to be changed out. I don't know. I'd have to look into that. Just know that it's an option. Bless you. All right, we are almost there. For your drug cards, for the anticoagulants, I don't know if you've already had anticoagulants anywhere.
You have warfarin, Rivaroxaban.
If you've already had them, then great. You've done them. I want you to be, though, aware of your anticoagulants. I want you to know, we're almost there, guys. Almost there. Heparin and enoxaparin are together. They are prothrombin inhibitor. I don't need you to know where they work. I just want you to know that they are, that you can recognize them as anticoagulants, okay? Warfarin helps. This one, none of them bust clots. None of them break down clots. They prevent the clot from getting bigger. None of these are clot busters, breakers, dissolvers. These are only, your clot won't get bigger. Your body will have to digest that clot. So if you have a big clot, we are going to put you on heparin, Lovenox, warfarin to keep that clot from getting bigger. We know it's there. We can't do anything about it. There are only a couple of clot busters, and their risk factors are so big, we don't usually use them. So if you think heparin is a clot dissolver, no. Heparin is a clot formation inhibitor. All right? So when you put someone on heparin, we are just acknowledging the fact that there is something there. We don't want it to get bigger. Whether it's a clot for your lungs, whether it's a clot for wherever, we're going to put you on heparin to keep that clot from getting bigger. Heparin and Lovenox do that. Or it will prevent it from happening in the first place. Heparin, Lovenox prevent it from happening in the first place, or prevent one that already exists from getting bigger. Warfarin, same thing, prevents clots from getting bigger. These are direct inhibitors. They are also bleeding factors as well. They're newer. The Xarelto and the Pradaxa are newer anticoagulants. They're very expensive, and they don't use them as much. They're used after cardiac issues as well for preventing clot formation. But they're pretty expensive. So heparin and Coumadin, heparin and warfarin are our standards, and then there are some new ones coming up, but they're still kind of expensive. So they may get put on those or not.
So you're going to have those drugs, and we're going to need to recognize them as anticoagulants.
I want you to know that they're anticoagulants.
Okay.
If you see them, just know they're anticoagulants.
What are just the names of the ones that dissolve?
I think I put them in here. Did I take them out? Yeah, they're here. They're coming.
Okay.
So this is just a drug. This is a little pharmacology section. With all anticoagulants, if you recognize them and you're like, ooh, anticoagulant, what do I want you to do? Watch their lab work, okay? They're going to prevent clots from forming, but they're also going to prevent clots from forming. So what's going to happen if you cut yourself? You're going to bleed. All right, you are at a bleeding risk. You're not going to just spontaneously bleed, hopefully, but any injury you have, the only way that you're going to clot up is with your platelets, because we've inhibited or slowed down clot formation. So you're not going to make clots. So you're at very high risk for bleeding. So high bleeding risk. If you see any of those anticoagulants, just know I'm at a high bleeding risk. I need to monitor my clotting labs, which are PT, PTT, INR, and I need to watch for signs and symptoms of bleeding. And this is where we'll see, if we're looking at labs, we'll see them in bleeding, because your hemoglobin hematocrit is your blood count. So if you're bleeding, your blood count will start to drop. But we're going to watch for signs of bleeding on our patients, and we're not going to poke them too much and stuff, because we're not allowing clots to form. So let's not poke them as much as we should. Maybe this is not the best time to put in a Foley. Sometimes you have to, but these patients, they put in a Foley, they may bleed around that Foley because they're on a anticoagulant. If you do have heparin, heparin has an antidote, the other ones do not. So heparin has an antidote, the others do not. I'm not going to ask you about the heparin antidote, but if you see protamine, that's what it's for. It's a heparin antidote. It stops heparin action. High bleeding risk. Anyone that's on an anticoagulant, I want you to watch these things for them. Anything, whether you're teaching them about it or you're watching for it, if they're on an anticoagulant, they need to know that if they see any of these things to report it. If you see any of these things, report it. We don't expect this. This is stuff that we don't want to happen if they're on an anticoagulant. We don't want pink, red, dark brown, cloudy urine. What?
For the watching for bruises, like is it an excessive amount of bruising?
Yeah, an excessive amount. I mean, yeah, you're on an anticoagulant, you're not going to clot. If I jar my elbow, it's going to bruise. Yeah, I wouldn't be like, oh my God, any bruise, report. If you're starting to bruise when you didn't do anything to yourself, maybe you should see somebody. So maybe we should say, watch for hematoma, bleeding, oozing, unexpected bleeding, oozing. If you poke someone and you pull out their IV and they're on an anticoagulant, yeah, they're going to bleed for a while. You're going to have to hold pressure a little bit longer than you normally would, because they're not going to stop bleeding right away. So watch for bruises, maybe unexplained bruises that you can't explain, especially if you're on an anticoagulant. Pink, red, brown urine, that means they're bleeding from their kidney or something. We're going to have to look into that. Red, black stools, what is that? GI bleeding. What is red or dark brown vomit? That's upper GI bleeding. Nosebleeds that can't stop. Avoid injections or IVs if you can. Okay, that goes for any anticoagulant if you see them. There are, and then of course the patient stuff. It's just kind of like, hey, here's all the things that you should do. Don't go scrubbing your teeth. Don't go shaving with a regular blade, a straight blade. We'd rather them not shave at all if you're on an anticoagulant, but we're not going to tell people to not shave. So an electric shaver is less chance of nicks and cuts than a straight blade. Don't shove things up into your GI system. It'll bleed if you rip it. So just basically, it's common sense. Don't do things that are going to make you bleed because you're not going to clot. Okay? Why no aspirin? Non-steroidal anti-inflammatories and antiplatelets. Aspirin is an antiplatelet. That will be non-steroidal anti-inflammatories can cause GI bleeding, so we want to hold them on those as well because we don't want GI bleeding. And that's why it says any other over-the-counter. It covers almost anything. We don't want anything that's going to cause any kind of side effect of bleeding. And aspirins are an antiplatelet. So we're already anticoagulating, so they can't form clots. Platelets are our first-line clotters. If we cut out your first-line clotters and your second-line clotters, you're really not going to clot. So when we take out both systems with an antiplatelet and an anticoagulant, we're really causing a problem to these patients. So an anticoagulant means your clot's not going to get bigger. An antiplatelet means you can't make a clot to begin with. So there are two systems for clotting, coagulation and just clotting. Platelets are making the first clot, and then coagulation makes the secondary clot. So an anticoagulant will keep you from making that secondary clot, but your platelets still work. We might sometimes decide to knock out your platelets so that your platelets don't work. And that is aspirin, Plavix, Peripheral, Integralin. You'll see all these on your patients that are post-cardiac. Why would we put these on cardiac patients? Why do we give aspirin for Mona? No more clot. We have a problem. We can't have any more clotting happen. We have a heart attack happening. No more clotting, okay? We've already got a blockage. We don't want any more. So we basically, it says you thin the blood. It doesn't do anything to the blood. It just keeps you from creating platelet clots. So as your blood travels through stuff, if it comes across something weird, platelets clump up on it until they can get it fixed. And so we don't want any of that clumping happening. Clumping causes more occlusion, so we stop the clumping. And those are the meds that stop clumping. And so if you're on an antiplatelet, it's the same thing as an anticoagulant. Just watch for bleeding, okay? Aspirin does have an extra thing of it could be toxic. If you haven't come across it yet, have you talked about aspirin toxicity? If you have, it's just extra. But what I'm looking for from you is that if these patients are on anticoagulants, I just want you to know that they're a high bleeding risk. Monitor their labs, monitor for signs and symptoms of bleeding. I want you to just recognize them. And they're extra, they're not part of this, but they're so important to DVTs and that I put them in here in PEs. And if you haven't gotten them anywhere else, they're here for you. These are the clot busters. I will not test you on clot busters. You will not be giving clot busters. TPA and streptokinase are the two clot busters. Those are the only two things that actually dissolve a clot. TPA is what our body does. That's what the heparin is buying your time for your TPA. You own TPA. Your body makes tissue plasminogen activator. That is what breaks down clots. So heparin is buying you time for your own body's TPA to dissolve the clot. If that's not going to work in a timely fashion and you're losing brain or heart, they may kind of go this way and give you an extra dose of TPA. But you make TPA and you have TPA. How do you think a clot that you formed from a cut goes away? TPA breaks it down. You have TPA in your body. We don't want to add more to your body unless we have to. And that would be stroke or heart. Or a severe pulmonary embolus that's really, we might bust that clot up. Otherwise, anticoagulant to keep things from happening. Your body's TPA will take care of it. Again, don't worry too much about thrombolytics because you will not be giving them. But you may see them in clinical. And just know those are the only things that bust you up. Okay, we're done.